Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today is Taylor Goldberg. Taylor and I are going to be diving into the concept of hypermobility, including what it means to be hypermobile and a variety of considerations for the hypermobile individual, including how we might want to go about assessing them, what kind of interventions we should or shouldn't do, and so on that way. This is a really great chat with Taylor, and I really appreciate her time and her personal tie-in with this as well. Episodes like this are made possible by our sponsors, ISOFIT and Oro Muscles. ISOFIT is my go-to for all things isometric strength training, and Oro is my go-to for surface EMG analysis. For more on ISOFIT and Oro, you can check the description below. Enjoy. Taylor, welcome to the podcast. I'm super excited to work with you today. Thank you so much for being here.
Yeah, thanks for having me.
For people who might not be familiar with you or this whole concept of, I guess I'll call it the hypermobile chiro, for lack of a better way to put it, would you mind filling them in a little bit about who you are and all the amazing things that you do?
Yeah, so I'm a chiropractor by trade, but I now have transitioned and call myself a hypermobility coach. I work completely virtually with something called hypermobile Ehlers-Danlos syndrome or hypermobile spectrum disorder, which we're going to define both of those today. But basically, I work with a group of people who have been really neglected by the healthcare system and have become really confused about their bodies. And I try to change that for them.
I think that's amazing that you do that kind of work day in and day out. And you're absolutely right, because as we're talking, I see a lot of athletes in particular in our practice who come in and they have ridiculous amounts of joint laxity. And it's incredible to me the positions that I can put some of these athletes into, and they've just kind of been told that it's normal, or they've been told that, hey, I know you feel tightness there, you should probably just stretch it. When in reality, I feel like the bigger picture of instability and laxity is kind of going neglected for the most part.
Yeah, I also think it's really misunderstood too. I hear from my clients all the time. They'll go to a PT or they'll go to their chiro and they'll be told, you have the tightest muscles ever. And then they can do a full split without stretching at all. Like, let's put two and two together. And so let's start with just some definitions. So ligament laxity is what can present if you have what is called hypermobility, which is when a joint goes past the natural or normal range of motion defined by anatomy, if you will. When you have hypermobility, you can have 4 different types of hypermobility. For the sake of this conversation, we're going to be talking about something called generalized joint hypermobility, which means 5 or more of your joints go past their end range of motion. If you have generalized joint hypermobility, that can be split into 2 segments. Asymptomatic generalized joint hypermobility does exist. Those are the people we're probably not going to see. They're not coming to us. They're not in pain. They don't have any issues. They get to use their hypermobility to their advantage, live their best life. They don't need to be scared about this. The other part and the more common part and the ones that we deal with are symptomatic generalized joint hypermobility. And you can get this from 1 or 2 things. It can either be acquired, meaning you got it from a traumatic incident like a car accident or a sport like gymnastics or cheerleading or dance. Or it can be genetic in nature, which would be labeled as a genetic connective tissue disorder. There's a lot of different types of connective tissue disorders, but the one we're going to be talking about today is something called hypermobile Ehlers-Danlos syndrome.
I think you bring up a great point in the sense that there's a lot of different buckets we can put the hypermobility into, and we could probably do a podcast episode on each one and still just scratch the surface about how complex this issue is. And I think that's an important point as well, as a lot of times we look for simple solutions to complex problems. And at the end of the day, we can only simplify this so much because there are a lot of factors that go into it. And you mentioned how genetics can play a role. You mentioned how certain sports can play a role. And sometimes those things can actually overlap, and genetics and sports can both increase ligamentous laxity. So understanding that, there's multiple pieces to this puzzle. And I think that the other piece that I really want to touch on real quick is you brought up the component of in generalized hypermobility. It takes about hypermobility at about 5 different joint regions to, diagnose that or consider that. And I think it's something that it's so easy to assess that clinically. And a lot of times providers have been taught for years to look above and below the involved joints already. So it's like you're already doing the majority of this stuff in your assessments from a clinician standpoint, or even if you're a strength coach, right? Most strength coaches have some kind of formal evaluation process when they bring a new client on or when they start working with a new team or something like that. So this is the kind of thing that you can very easily bake into an initial assessment and be able to actually catch early on and have a positive impact on, because I don't think that this diagnosis should scare someone out of sports or out of activity. If anything, it's just a matter of how we adapt what we do to them.
Exactly. And I think we overcomplicate even the screening for it. Like if you're already doing a full screen on range of motion in every joint, if that joint goes past that range of motion, it's considered hypermobile. Like we don't have to do the Baton scale or any of these other scales to define when somebody is hypermobile in these regions. Just look at the person in front of you. If they have extended range of motion in 5 or more areas, that's something that we want to talk about and use to our advantage. It doesn't have to be this fearful thing, but what tends to happen is a clinician will say, oh yeah, you're hypermobile to a patient. There's nothing we can do about that. Or yeah, you're hypermobile, but I don't know enough about that. That's unacceptable. If you don't know the answer, say to your patient, I don't know what this means for you, but I'm going to find somebody that does, because your patients deserve better than that.
I completely agree. And it's so interesting because a lot of times we note these things and then we just kind of brush them to the wayside. And I think that in general, having an understanding of how the body works from a mobility standpoint and how it works from a stability standpoint, to me, that's kind of like the bread and butter of what gets done in the physical therapy, chiropractic, and even strength and conditioning worlds, really.
Yeah, exactly. I'm in my own little echo chamber here and bias here, but like we're so focused on finding these like little muscular imbalances and these little things that in the grand scheme don't mean much, yet we don't ever pay attention to how is this joint moving? What does that mean for the person in front of you? How could that be playing a role in their pain story? And like we said before, there's always more than one component to everybody's pain story and everybody's movement story. And we need to take all of them into consideration.
Do you have a generalized flow that you use when you're working with clients and athletes that you work with that way on your hypermobility coaching side? Or how do you go about approaching that initial conversation with someone? What kind of things do you consider around the topic of hypermobility? What do you really want to know from that initial consult or assessment that way? What kind of things do you really put a lot of stock and emphasis on in this world?
Yeah, so I like to describe this as you're going to see 3 different types of hypermobile patients. You're going to have the type of hypermobile patient that knows they're hypermobile. They've gone down the Reddit rabbit holes. They've learned all about it. They have lots of questions. You're going to have the one that has seen it on TikTok and they think that they might have this and they want to learn more about it and see if it's a part of their story. And you're going to have the ones that have never heard of this in their entire life, but you notice as the clinician that this might be a part of their story. And we're going to need to treat those 3 very, very differently. And so on an initial evaluation, the whole goal, I don't believe behavior change or really any change can happen in the first visit. So the first visit is really ruling out red flags and building rapport and building trust. And so that's going to be my main goal. And I'm going to do that differently based off those 3 presentations. For the person who already knows they're hypermobile and they really want to learn more about their body and how it's impacting them, we're going to look into a lot of different things, including something that we label as comorbidities. So something that's really common in this population is something called mast cell activation syndrome and something called dysautonomia, or if you've heard of POTS, that's a type of dysautonomia. And these drastically change our exercise and treatment plan. And so if something changes our treatment plan, we have to look into it. We have to take account to it. But from a purely movement-based standpoint or exercise-based standpoint, I'm going to see what areas are hyperextended. Do we feel more comfortable and are we more confident when we lean into that hypermobility? Do we maybe not have the interoception, like knowing where our body is, or the proprioception, your body's ability to know where you are in space to get out of those hyperextended positions? Because it's not necessarily bad to be in the hyperextended position. We just have to know when we're in it and be able to get in and out of it as we please on our own terms. And so we're going to take a look at that. And then we're going to look at some common musculoskeletal comorbidities that come along in this population as well. So just to name a few, upper cervical instability should always be ruled out in these patients. If they're experiencing headaches of any sort, Chiari malformation as well as CSF leaks are more common in this population. As far as lower body goes, hip dysplasia, not kid hip dysplasia, but adult hip dysplasia, especially gymnasts, cheerleaders, dancers, it needs to be evaluated. It is not talked about enough.
Yeah, no, you covered so many amazing points there. And just to kind of run it all back here, first off, I think the importance of the subjective component of the examination cannot be overlooked, especially in this population, because you want to find out what they know, what they think they know, and what they don't know. I think that education here is a huge piece, because I think there's, like we've already talked about, there's a big misunderstanding around the concepts related to hypermobility, and understanding where your patient is currently at and where they need to be. I think that has to be the first and foremost biggest rock that we have to tackle, so to speak. Moving on from that, I think that you mentioned the joint assessment, and I think that the way you broke it down as far as the positions, the proprioception, and so on, that way is essential. I think a lot of times we like to look at, well, how much does it move, and how strong is it in a basic manual muscle test position? But I think it's really easy to go beyond that. Plain and simple, if you take that basic manual muscle test that we just mentioned and you just do it in different positions, you can understand how strong someone is at different ranges of their joint that way. So understanding that it's really simple to break down how strong they are or how well they are able to sense where they are in space, simply by just changing the joint position and doing the things that you're already doing anyways. And I really like that you brought up the comorbidity side of things, because I think this is another thing that I typically don't hear about enough in the sports world. A lot of times people tell me, well, I want to work with athletes, and they think that every athlete is going to be 100% healthy all the time. They might have an orthopedic issue that they're going to rehab, but they don't ever think about all these other things that can impact it from a medical standpoint, or even medications that can play a role in ligamentous laxity as well. A lot of that stuff just gets brushed to the wayside. And I think at the end of the day, you have to understand that we're in a healthcare industry. We're providing healthcare, and a part of healthcare is understanding the diagnoses and the medications that can have an impact on how someone is presenting to us from a musculoskeletal standpoint. And I think if you're missing that deeper physiological mechanism or physiological understanding, then ultimately you're not going to be able to get the kind of results that you're after in this population, because you don't understand the underlying factors that contribute to it.
Yeah, exactly. And a bigger piece of this too is the consistency, or having, like we hear it all the time, your patient didn't do what you said or didn't do their home exercise program. Like, that's on the clinician. And if they are dealing with comorbidities that aren't being addressed, and they are so fatigued, and they have unmanaged ADHD, and they have that all or nothing mindset, it might not have anything to do with the exercises themselves. And there might be other barriers at play that you didn't dive deep enough into. And we need to address all of those barriers to get somebody to be consistent with their exercise program, which is a lot of the times our big end goal. And going back to that initial evaluation, I'm completely virtual. I literally give them their workouts, and they do their workouts, and that's their evaluation. It doesn't have to be more complicated than that. Do what they're already doing or what they want to be doing, see where the barriers are, and work on those. Start there.
We mentioned earlier how this is a complex problem, and we can simplify it to a certain extent. But if you see what they're already doing, I think you can take away a lot from it. And that's an answer that's right in front of you. Yeah, there's a lot of stuff to assess from that, but in reality, I think you can gain a lot of knowledge from seeing what they're already doing. Because again, going back to that subjective component, it'll show you where they feel they're currently at, what they're able to do, and so on that way. So I like that approach a lot. And the other thing that you had touched on, you mentioned the EDS and cervical instability as well. And in the athlete world, we tend to see athletes get concussions for some reason. I don't know why. Football, some of these other different sports for some reason. And one of the things that I've really tried to hone in on and make sure we don't miss is the cervical instability in this population. And I think it's something that we take for granted. Well, they went to the ER, they got their x-ray, so it's going to be fine. Or, hey, they went to urgent care, now they're here at PT, so we're good to proceed. And I think that this is certainly a population that we really cannot take anything for granted. And we have to always act under the assumption that this is the first time they're being seen for the issue. Because, correct me if I'm wrong, but I believe the cervical instability side of things, like you can only see that on certain x-rays, certain films. Like I think the open mouth x-ray was the standard for a while anyways. I'm not sure if it still is. It's something that they're not often assessing in urgent care. They're not assessing in ERs a lot of the time. And, that's not to bash them by any means. I know they have a lot of different things coming in and out of there, and they have to cover a very broad array of diagnoses, but understand that there could be things that were missed by other providers. And that's not to blame the provider. That's to say we just need to do better for the patient in front of us.
I love that. And yeah, so the gold standard now for upper cervical instability diagnosis is an upright MRI, which is extremely hard to get and extremely expensive. And every state doesn't even have one. And so imaging always is one piece of the diagnostic journey. It is never the entire picture. And so when it comes to upper cervical instability, the biggest thing is taking a really thorough history and asking the specific questions and symptoms that relate to upper cervical instability. And the big ones would be, when you move your head, are you getting neuro symptoms? Do we have any vision changes? Does your head feel like it's too hard to hold up, like you have a bobblehead almost? And then doing a physical exam with a cranial nerve exam, and then getting imaging. And if you cannot get an upright MRI, a flexion extension film is the least barrier. And then next would be a DMX x-ray, and then it would be the upright MRI. But you can't see upper cervical instability on a supine MRI, which is what they're doing in the ER. So they can't even evaluate for that, even if they wanted to. So definitely important to keep that in mind.
Yeah, no, and I think that's a great point. And on this concept of upper cervical instability, typically if I've seen it or I've had concerns about it, it's not one of those things. Like I kind of break things up like a red light, yellow light, green light kind of thing. And it's not really something I would put in the green or the yellow. Like we're not going to try and tread around it. Like if this is something that I'm genuinely concerned about, I'm actually going to pump the brakes on this one and send them to someone to get to the bottom of it before we continue, just because we're running, with some really risky structures here. And I would rather measure twice, cut once, as opposed to trying to test the depth of a river with both feet.
Exactly. And the thing with upper cervical instability too, is there now becomes things that the person in front of you can't do, like traction on their neck, or I'm a chiropractor, so adjusting your neck. Those are extremely dangerous if you have upper cervical instability. So it's something we all need to be screening for. If you are doing manual therapy in that way, it should be just a part of your normal screening, because you can seriously injure people who have this and you weren't aware because you didn't do a proper screening. It also can drastically affect our exercises. And if we are getting symptoms while exercising, upper cervical instability, meaning your first two vertebrae are unstable, they can become so unstable that they can hit your brainstem and you can pass out while you're exercising. That's dangerous. We need to address that. And I'm not saying this to scare people or scare anybody, but it's just something that we need to take a little bit more seriously. And then the good news on all of this is that for 95% of people with upper cervical instability, conservative care is the top line treatment. Surgery is only applicable to 5% of people with upper cervical instability. So there are a lot of options, and there's a lot we can do as physical therapists and chiropractors for this.
Yeah, no, I definitely agree. And I love that you bring up the concept of manual therapy and the hypermobile athlete or the hypermobile patient, because this is actually something that I've had pretty good results with. And a lot of times people hear that and they say, wait a second, well, typically manual therapy is done for increasing range of motion. Why are you doing that in someone who's already got enough range of motion? Or, they go back to the textbook and they say, well, this is contraindicated, so why are you going to do that? But in reality, I think we need to understand that from a manual therapy standpoint, there's more going on than just increasing range of motion. And as you mentioned earlier about the proprioceptive side of things, I think a lot of what we do from a manual standpoint is really neural driven mechanisms. So if I can use something to modify the nervous system around a joint or around a selected tissue or what have you that way, and then open up a window for us to, I don't know, reduce symptoms or possibly like intervene more accordingly from an exercise standpoint, I'm going to take that transaction every single time. But, from your side of things, having that chiropractic background, how would you look to incorporate manual therapy into the hypermobile athlete that way? Soft tissue work, joint mobilization manipulation. What kind of things are you looking at, considering? Do this, don't do that. Walk me through kind of the tailored process on this.
Yeah. So the first most important thing is safety. Is it safe for me to do manual therapy on this joint or on this area? And risk versus reward, and letting the patient know the entire informed consent, a true, proper informed consent. What are the benefits of this manual therapy? What are the risks? What are the other options I have that might do the same thing? That needs to be told to every patient, especially patients that are hypermobile, before you do manual therapy. When it comes to the neck specifically, HVLA adjustments, so the typical chiropractic adjustments that you see on TikTok and anywhere with the loud cracks, are completely contraindicated if you have a connective tissue disorder. There is very good reasons for that. You are at a higher risk of a CSF leak. You're at a higher risk of upper cervical instability. The risk is not worth the reward, and we can get the same benefits from a lot of other manual therapy or passive modalities that an HVLA adjustment can do without that risk. And so when it comes to the neck, I don't generalize a lot of things, but I will generalize for somebody with a connective tissue disorder. An HVLA adjustment on the neck should just never be done. You can do soft tissue work. You can use the activator. You can use a massage gun. You can use all the other things. Just do not do an HVLA adjustment. It is not worth it. For upper cervical instability specifically, traction on the neck is also contraindicated. So make sure you're screening for that and keep that in mind. For the rest of the body, it's really about what is the patient's preference? What do they like? What have they found relief with in the past? And then we kind of go about it like that. I mean, I'm completely virtual, so I'm not doing manual therapy on these patients, but I always refer if it's something they enjoy and they get benefit from. And I also like to teach them how they can start doing it themselves. How can they start self-managing this themselves, using lacrosse balls, using their own hands, things in that realm.
It's something that, as you alluded to, I feel like it has to be individualized to every patient that we work with that way. And a majority of the time, I'm noticing in the athletes I work with, we tend to see a lot of laxity in the hips, in the knees, in the lower extremity, kind of throughout the lower extremity chain. But there tend to be certain spots in the spine, in particular, the thoracic area seems to be one that gets kind of like restricted in a lot of these athletes. And I can't tell you if that drives increased compensation as some of these other joints. I think it's a chicken or egg kind of scenario. But I have noticed that, a lot of them, we can improve thoracic mobility and actually reduce symptoms at some of these other regions, like the hip and so on that way. So I think that, like you mentioned as well, educating the patient that there's more than one way to skin a cat on this. It's like, hey, look, we could do mobs, we could do these exercises and do the same thing, or we could do a manipulation. It's going to take us 30 seconds to a minute to do, and then we can move on and have more time for X, Y, and Z. So understanding that there's definitely a time and a place for this. I think the other piece as well is just because someone has hypermobility and it might be a joint type thing doesn't mean that you should skip soft tissue assessment. I think that the art of palpation is extremely lost. I know trigger point theory is still theory in the sense that, muscles can develop X, Y, and Z because they're acting as both a primary mover and a stabilizer at the same time. However, I've noticed a lot of times people come in with pain and they have some gnarly feeling tissue. And when we make that feel better, their pain goes away and it seems to stay away for a prolonged period of time. So understanding that, just because it's a joint piece here that we're looking at doesn't mean that you can just not pay attention to the soft tissue. I think it's still a matter of making sure that you assess everything, check all of your boxes. And I think the more that you do that, the more you're able to intervene accordingly as well.
Yeah. And I think it's actually, and this might be my bias, even more important to check the soft tissue in this population. What you'll hear from this population most commonly is they feel really tight. Everything feels tight on them, but then you look at their range of motion and they're not tight. And so the reason for that is because their muscles are probably holding on. They might have had subluxations. Yes, true medical subluxations, not chiropractic subluxations. Those happen in this population. It happens a lot, and validate that and tell them that that is real, because they've probably heard it from 10 practitioners that that's not a real thing. It's a real thing. There's a lot of documentation on that too. But when something medically subluxes or partially dislocates and comes back in, the muscles surrounding that area go into spasm every single time. And so if we can help with that and we can make that feel better, that can create safety in our nervous system, which is a huge component of all of this, so that we can get to our movements easier without as much tightness feeling, whatever we want to call that, trigger point, whatever. I think Greg Lehman calls it painful spots, like whatever we want to call it is fine. We're all doing the same thing. And just make the person in front of you feel better with what they're describing to you. Ask good questions.
As you mentioned earlier too, this is definitely an area where I feel like you can certainly teach patients how to do a lot of things on themselves. I mean, Kelly Starrett wrote a whole book about it called The Supple Leopard. So I think that there's certainly a lot of things that we can do clinically. And I think that from an assessment standpoint, nothing is ever going to replace a good manual therapy intervention. However, I think that it is important to know that we should certainly try and teach patients how to manage these things on their own, not get 100% self-relief, but it can certainly help. And having tools in the toolbox that people can use to, help manage their symptoms, because hypermobility tends to be something that I've seen in athletes at a young age that seems to last. It's not like, oh, well, it's going to go away once you stop doing sport. It's like, this is going to last for years and years and years. It becomes a more chronic thing that way. So understanding that, I don't want them to become a chronic patient who needs to see me 2 to 3 times a week, every single week for the rest of their life in order to feel good. Understand that there might be times when things flare up and they need to come in. But for the most part, if they can manage it 80 to 90% of the time on their own, then I want them to be able to do that.
Yeah. And that's my goal with all of my clients. And I upfront say, if you are in chronic pain and you have a connective tissue disorder, flares are a part of your story. Our goal is not to have 0 flares. It's not realistic. Our goal is to be able to have our flares be an annoying thing that happens every now and then that never debilitates us. And we can do that by finding ways to get relief on our own terms so that you can go on vacation again. I have so many clients that are scared to go on vacation because they're scared they're not going to be able to see their chiropractor to get that relief that they need. That's a problem. If we're so dependent on somebody else that we can't even go on vacation, we're not truly living our life. And so as clinicians, we can use manual therapy to our advantage and help in those situations. And it can be so valuable and so beneficial, but it can't be the only thing.
No, I completely agree. And on that note as well, since manual therapy can't be the only thing, exercise obviously plays a key role in what we do and how we intervene that way. And you mentioned that you're fully virtual now, so that's a large part of what you do with your clients, I'd imagine, is exercise interventions that way. So from exercise intervention in the hypermobile patient that way, where does your head go around that topic? What kind of things do we like? What kind of things do we not like? What kind of things have we seen that we really haven't appreciated or seen results from other clinicians as well? I guess I'll throw in.
Yeah. So the biggest thing in the exercise world when it comes to hypermobility is this narrative and idea that strength training is dangerous and that Pilates is the end all be all. That's what you'll hear in this space. And there's nothing wrong with Pilates. If you like Pilates, do it, but you also need to get strong muscles and you need to strength train. What we know about people with connective tissue disorders is that usually we take longer to heal in general. We have slower wound healing. We take longer to build muscle, and we process things a little bit slower. So things are a little bit harder for us. And so knowing that as a clinician, start small, as well as it's okay to repeat yourself multiple times and explain things in different ways and give external cues a lot. I find that this population does really well with external cues, much better than internal cues, because a lot of us struggle with understanding what's going on in our body and feeling our body because we've been in pain for so long, or our body hasn't made sense to us. And then we go to a doctor and they're like, yeah, no, that doesn't make sense. And then that belief is more confirmed, more confirmed, more confirmed. And so I do strength training with all of my clients. If they do have POTS or a type of dysautonomia, we are also going to incorporate cardiac rehab because that is standard for that disorder and necessary. And just really, I'm a goal dependent person. What are your goals? What do you want to get back to? What has stopped you from that? And then we're going to kind of go from there. I will say majority of my clients are past gymnasts, cheerleaders, and dancers, because when you're hypermobile, those are the sports you are really good at. And that's what we usually like to go to. So I have a lot of fun being able to program and do things like handstands and things like that with my clients.
Yeah, and it's so interesting because from a clinical standpoint, I tend to lump those three sports together as well: gymnastics, dance, and cheerleading. And a lot of those sports teach body control and body awareness, which I think is so essential for this population. And a lot of times I noticed that they kind of become more symptomatic after they stop their sport, because they stopped the loading and the strengthening that goes into a lot of them. In my opinion, anyways, I think that plays a role. Thinking about gymnastics in particular, I've seen, female gymnasts be able to crush more muscle ups than I can crush. And it's really impressive to watch, but it's also like you have to understand the amount of strength and power that goes into that from a muscular standpoint. So a lot of times I think that continuing to train and intervene and using their past history to guide that, if they come from a gymnastics or cheer or dance background, you can probably accomplish a lot with body weight calisthenic type training. On that note as well, as you mentioned, it is perfectly safe to incorporate weights here, but I think it's the kind of thing that you just have to know what you're doing and understand what stimulus you're applying to the body, and understand that there are certain positions that are going to be more vulnerable for them as well. So I think about the baseball pitcher and the throwing shoulder as a great example. Is, that way far back layback type position is a very unstable position for the shoulder. And I've seen people different times trying to do exercises that target that position. And while I'm all for loading those areas that we are unstable, we just have to understand what we're doing, how we're doing it, and make sure that it's a safe thing, because it can become very easy for us to turn, a strength exercise that's hopefully going to help someone into an exercise that ends up causing a little bit of harm because we loaded too much or too fast into a very unstable position in someone who's already unstable.
Yeah, absolutely. And also a big component of this is the tempo at which they're doing their movements. So we see a lot with hypermobility. They'll use their mobility to their advantage because it's easy for them and because they can. And so they'll speed through things, and then they don't really get that muscle activation. They're not feeling it in their muscles. That is something that needs to be addressed as well, and making sure that we are doing it at a good speed. And then when it comes to like end range loading, there's a time and a place for it. And that time and place is not always, and that time and place is not never.
We've touched on the individualization point a number of times in this podcast. I think that exercise has to be a place where we individualize as well. Too often I see patients go to, PT clinic, or they'll jump around to multiple PT clinics and they all treat them the exact same way. And it's probably 10 to 12 exercises that would pop up on a Google search if you typed it in. And I just don't see that being the solution for, this population. Like, I think about shoulder instability as an example, and I don't really treat that with 3x10 band IR, but
No.
A lot of people try to.
Right.
And they're surprised when they don't get results. So understanding that there's a lot more than meets the eye to things, and that we actually have to put a little bit more effort and energy into how we intervene from an exercise standpoint, as opposed to just the basic 3x10 flow sheet.
Yeah. And also there's a lot of protocols in this population. You'll hear Medalny protocol, Levine protocol, CHOP protocol. There's nothing special about any of those protocols. They were just named after somebody who decided to market something really, really well. I unfortunately see patients getting scammed a lot. They'll be like, oh, but they're using the Medalny protocol, so they must understand hypermobility. Not necessarily. Ask deeper questions. And if you are a clinician, in my opinion, you should never just be blanket copying a protocol and expecting it to work for every single person just because they have that diagnosis. That's just not how the human body works. We can't generalize these things.
You mentioned earlier about the tempo component as well, and I'm definitely a huge fan of eccentrics in this population, because I find a lot of time the whole understanding of eccentric control has gone missing. I also do a decent amount of isometric exercise in this population as well, because going back to what we talked about from an exam standpoint, there's a big mismatch here between the range that they're usually able to achieve passively versus what they can do on their own, and understanding that we need to kind of bridge that gap, because I usually get pretty concerned on the sports side of things when I see someone able to rotate their hip 100 degrees passively, but they themselves can only get it half of the way there. To me, that's a major injury risk factor, knowing that a joint can move into a huge position like that, but we can't actually control it, or we don't have any kind of like muscular stability there, or we haven't built those neural connections yet. So I think this is an area that if you teach eccentric control and you teach static stability from an isometric standpoint, you can certainly make a lot of gains, a lot of improvement in a very short amount of time, a lot of times too.
100% agree. And like, I'm a big fan. A lot of the people I work with have ADHD. And so habit stacking, creating dopamine around isometrics is my favorite way to incorporate them, and doing them throughout your day instead of making it this like big task for yourself can go a really long way. And just doing a couple every single day consistently over time can really make a big difference.
It's so interesting you say that, because we just recorded a podcast yesterday. Actually, we recorded it. And on the podcast, Michelle Pfeiffer, who's a strength coach with Rutgers University, talked about how she microdoses isometric exercises with her female athletes every single day in the work that they do. And it's like, here's a whole team of female athletes. They got 40 or 50 on the team that way. They're all, playing a field-based sport. And it's like, hey, we're going to do 4 of these every single day. And I think that that's something that anyone can incorporate that into their routine, especially because for the most part, this is not something you need fancy equipment for. You can if you want, but like you can get a lot of benefit out of just holding a certain position that way.
Exactly. I love that. I'm a big fan of it. I use it with every single one of my clients. I think it's really important.
We've talked about the gymnastics, dance, and cheerleading, multiple times throughout this podcast. And in the athlete world, there's plenty of other sports that play into this as well. Does hypermobility tend to be a limiting factor for athletes who want to play other sports? You mentioned that it kind of leads you into gymnastics, cheer, and dance because you're going to naturally be good at that. But should athletes shy away from playing like a softball or a lacrosse or some of these other sports because they have hypermobility? Or, how can we possibly adapt the sport to their needs that way? Because I get a lot of questions about taping and external braces and external stabilizers that way. Is that something that you feel is essential for the athlete to play a field-based sport? Or is it kind of nice to have, but maybe not a need to have kind of thing?
Yeah, so this is my own opinion, but in my opinion, there is no sport, there is no activity that is ever 100% off limits for anybody. I think we can modify every single sport to work for the person in front of us. It just might be really hard. It might take a lot of work. We might need a lot of extra help, but I do believe it's possible. That's my own opinion. Now, with that being said, as far as braces and using tape and external stuff, my answer is it depends. I do believe there's a time and a place for utilizing things like braces and utilizing tape, but again, it should never be 24/7. And so one thing that has come up in this population I get asked about a lot is the body braid, which is a basic full body brace. And I'm not a fan of that because there is nobody that needs to have every single joint immobilized at one point in time. That's just not how the human body works. And when it comes to braces, I think that we need to put time limits on them and we need to put rules around them instead of just saying, wear this brace. That's not enough. That's not clear enough. We need to give our patients more clarity on these things. Going back to the upper cervical instability piece, like it could be a pivotal piece of their puzzle to wear a neck brace during certain times to get them to be able to get back to their sport. So there's a time and a place for braces. When it comes to field sports and those types of activities, I think it is usually harder. And that's why we don't maybe see as many hypermobile bodies in these sports, but I definitely don't think it's out of the question or impossible. It just might be, we need to modify, we need to strengthen a little bit differently. We might need to have a PT on our team more. And especially the cardiovascular piece, when you have a connective tissue disorder, your heart can be impacted, and everybody with a connective tissue disorder should get an echocardiogram. And that might make it hard for them to do. Like I tried to do track when I was a kid and it did not go very well because of my cardiac system. So these are things that we just need to keep in mind. Could I have made it work for myself? Absolutely. But at the time I liked cheerleading more and it was a lot easier for me.
I was going to say you've been mentioning yourself a number of times throughout this podcast, but you haven't really dived into your own story yet, Taylor. So fill us in about your own kind of upbringing and backstory there, because it certainly seems like you've got a little personal history here.
Yeah, so I have hypermobile Ehlers-Danlos syndrome myself, so that is why I can relate to this population very deeply. I was a competitive cheerleader my whole life. That is where my heart is. That is where my passion is. That is still to this day how I train. I incorporate a lot of handstands and tumbling into my own training. I love it. It makes me happy. And that's kind of how I got to this point, and where I'm at is because I dealt with this myself and realized we can help people with this condition. And I didn't know that at one point, and I want everybody to know that now.
Absolutely. And I think the other piece, and you've kind of alluded to it throughout this episode so far, is I think that the language that we use around this population is so important. And I think a lot of times we as providers or coaches or clinicians, or however you want to say it that way, tend to focus too much on the restrictive element. Well, you have this, so don't do this or don't do that, or hey, this is risky. When in reality, as you've kind of alluded to throughout this podcast, I think a lot of times we can get people where they want to go. We just have to understand that it's a stepwise approach. It's a progression. We have to have some kind of framework in place to get them there. But just because you've been told you have a certain type of hypermobility or a connective tissue disorder doesn't mean that you should never go to the gym. Doesn't mean you're never going to go for a run. Doesn't mean you're never going to pick up a weight or anything like that. I think it might just mean that, hey, maybe we need a little bit more of a adaptive approach to get there, or hey, maybe we need a little bit more of a stepwise approach to get there. We might not be able to jump in from day one the same way that someone else might, but that doesn't mean we can't get to the same end goal at the end of the day.
Yeah, and creating those expectations up front, I think, is really important, and we don't do that enough. When you have somebody that's hypermobile and you see like, yeah, they're struggling a little bit more, it's okay to say, this is going to take longer than your friend. This is going to be harder for you than your friend. Just talk about that instead of ignoring it, and create realistic expectations so that they can feel like they're making progress and prove to themselves they are capable of things, because they probably don't feel that way right now. They have probably been shown and proven to themselves that things are harder for them and it's not possible for them because of that, when in reality, it's just they needed a little bit extra help that they didn't get.
And as you were talking there, I'm by no means a mental health expert or clinician or anything like that. And I don't pretend to be, but I certainly think as you were talking, this could be an area where I certainly see a great role for that mental performance or mental health professional to enter as well, because I imagine it can be very frustrating for this type of athlete that way, to constantly be told, well, it might take longer, or well, you'll get there, you just need more time. And I think that the more we kind of normalize that and have conversations around that and address it early, the better off we're going to be from a holistic standpoint.
100%. As far as care team creation goes, it's really important in this population. Mental health, always a part of the care team. Cardiologist, always a part of the care team. Somebody for the musculoskeletal system, always a part of the care team. And usually a neurologist too are kind of your basics when it comes to living with a connective tissue disorder.
Yeah, no, definitely. I think that the more that interdisciplinary team is able to work together, the better off it's going to be for the person at the end of the day. And that's what we're all here to do. We're here to help people. I think a lot of times people try to get so focused on all the things that they can do, and they try and be Superman and do it all themselves. When in reality, no one has all the answers. No one knows everything. And the more we all kind of collaborate together, the better off we're going to do by the people that we get to work with. On that note as well, I'm sure someone listening is going to have questions and they're going to want to reach out to you, Taylor. So where can they find you at online? Are you on the Instagram generation, or you mentioned TikTok before? Do you kind of pop up in TikTok every now and then?
Yeah, so I actually started on TikTok, but now I have officially become an Instagram girly. But you can find me on both TikTok and Instagram, the Hypermobile Chiro. You can also find me on my website. I also have a lot of resources on my website for both clinicians and patients. It's the hypermobilechiro.com. I also work with a chiropractic mentorship group called Clinical Concepts, and you can find that on Instagram as well.
That's awesome. We'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there. Taylor, is there anything that we missed as we were chatting today, or any kind of closing thoughts or closing remarks that you might have?
I don't think so. I think we pretty much hit everything I wanted to hit, but I guess like the one piece of advice I would leave, if you're a clinician watching this and you think you're not going to see somebody that's hypermobile in your practice, you're wrong. It is very common at this point. You are going to see somebody. You need to know how to address it. And if you don't, there's a lot of opportunities to learn. I have a course that teaches clinicians specifically how to treat this population. The EDS Society also has their own course called the ECHO program. Get good at treating this. It's going to come into your office. It matters. We need to do better.
100% agree. Taylor, I really appreciate your time and everything that you've offered us from an advice and insight and even additional resources through the podcast today. Thank you so much for being here and looking forward to chatting again soon.
Thanks for having me.